Okay, so I wanted to start off by letting everybody know that if you are unable to make any of these sessions, we have been working on our website. We now have asynchronous access available through the family medicine website. You just go to the Grand Rounds page, and from there you can click online recordings, and you can choose to view either with CME credit or without, if you want to go back and look at the videos as well from our recent presentation. So just wanted to share that information with you. Then for today's event, we have can you go to the next slide? So today's event for August 19th, we have the Family Medicine Grand Rounds. The event number is 232047. We do ask that you all sign in for CME attendance. This helps us, but it also goes onto your transcript. So if you would please just sign in there. In a little bit, I will be putting the information in the chat box as well for those who maybe come in a little bit later. So I'll get that information in the chat box here shortly. And we appreciate if you would keep your microphone on mute once we get started here, being attentive, being engaged, and then also towards the end here, I am going to put the evaluation link as well for the session, but if you'll help us out in getting those evaluations so we can give feedback to our presenters. And this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area Health Education Center, the South Central AHEC. The mission statement, inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. And I kind of already brought it up, but for those of you looking for CME credits, you can also access your transcript. You can go to the CME email address, or you can also give them a call if you have questions. Those interested in AAFP credit, this is worth 1 credit. You can go to their website, and their phone number is also listed there. If anybody has questions about any of it, you can also contact me. And the conflict of interest statement for this presentation, Dr. Teegala and Dr. Fernandez-Falcon have no relevant financial interest with commercial interest to disclose. So for today, we are presenting the top poems of 2019. In patients older than 75 years without cardiovascular disease, statins are not effective for primary prevention. So we have Dr. Sireesha Teegala, and I will let her take it from here.
Okay. Hi, everyone. Can everyone hear me clearly?
Yes.
Yes. Okay. Perfect. Hi, everyone. My name is Sireesha Teegala. I'm a PGY3 resident, family medicine resident, and here to talk to you guys about statins. So what exactly are statins? Just a brief introduction on this. It's HMG-CoA reductase inhibitors that improve endothelial function, reduce inflammation, and also reduce thrombus formation. So they're known to reduce morbidity and mortality in patients younger than 75. However, there's data lacking for individuals who are greater than 75 years or older. And they're also a pivotal component in primary and secondary prevention of vascular disease. Okay. So the objectives for this presentation are to identify if statins are effective in patients older than 75, compare the effects of statin therapy at different age groups, as shown here, and then also demonstrate whether major vascular events were significantly reduced by statin use. So before I start my presentation, I'd like you guys to just take a look at this question. If you have a patient that comes in who's an 80-year-old male, who has all these comorbid conditions such as diabetes, asthma, BPH, CVA, CKD, and hyperlipidemia, and has multiple medications, and he's currently on atorvastatin 40, what would you want to do for this patient? So I would just like you guys to think about it, and then I'll give you the answer at the end of the presentation. Okay, So in this paper, what they analyzed, this paper is unique because they took analysis of individual participant data in patients over 65, and they used 27 randomized controlled trials and one detailed summary from one trial with 4.9 years of follow-up. Of this, 14,483 patients were older than 75 years. And this is just a pictorial image of those methods. So the study design, it was a meta-analysis of individual participant data from 28 trials. And of those 28 trials, 23 were statin versus placebo/usual care. And the other 5 trials were intensive statin versus standard statin. So what is this placebo/usual care? That's basically just exercise or diet management that they use. And the difference between intensive and standard is intensive was basically a higher intensity statin. Standard was just a low dose simvastatin. Okay. And some of the baseline characteristics of these participants, the only thing I wanted to focus on was the difference in male and female on how many participants were less than 75 and how many participants were greater than 75. And then also for LDL cholesterol, what was their baseline cholesterol? Because everything was dependent on how much of their cholesterol was lowered and what effect of statin had on these patients. So as you can see here, the baseline on average for patients less than 75 was about 127.6 milligrams per deciliter, whereas patients greater than 75 was about 123.7. So the first question that was addressed in this paper was, what were the effects of statin therapy at different age groups? And the answer that they showed based on their data was that overall, statin therapy produced a 21% relative risk reduction in the first major vascular event per 1 millimolar reduction in LDL cholesterol. And it also showed significant risk reductions in each of the age group. Okay, and that's illustrated in this figure here. So as you can see on the left, these are the different age groups, and this is the experimental group with statin or more intensive statin versus the control group. And on the far right, it shows the relative risk per 1 millimolar reduction in LDL cholesterol. And in this part of the figure A, it includes all the studies, and they specifically excluded 4 trials which had exclusively heart failure or patients that were on dialysis. And the point I'm trying to make in this slide is to show you that in patients greater than 75 years, there was a 13% relative risk reduction in LDL cholesterol, in major vascular event, per 1 millimolar reduction in LDL cholesterol. Similarly, you also see that in the bottom figure, where you have this was for participants without any baseline data. So even without any baseline data, you do see that statins did have an effect on these patients, and it did reduce their risk in major vascular event. Okay. And the second question that was addressed was, what kind of effect did these statins have on major vascular event? And they showed that overall, almost every single age group had a reduction in relative risk of major coronary events. However, in patients greater than 75, there was no reduction in coronary revascularization or stroke. And it also showed that there was a 25% proportional reduction in the risk of coronary revascularization with statin therapy. However, there was no significant difference among different age groups. And similarly, there was also a proportional reduction in stroke. However, it didn't differ significantly by age group. And that's again illustrated in this graph here, in this figure here. So as you can see, for the major coronary events, almost all of them have relative risk less than 1, which means that the risk of the outcome is decreased by the exposure. And in this case, the risk of the outcome would be the vascular event. It's decreased by giving them statins. And you can also see that in patients greater than 75 years of age. And it also shows that there was a significant difference there was a decrease in relative risk among all the patients in different age groups. However, in patients, but before I move on, for major coronary event, it was defined as patients with non-fatal MI or patients with coronary death. And then for coronary revascularization, it was patients who had to go through angioplasty or bypass grafting. So as you can see, similarly, that there was a difference among the different age groups because the relative risk was less than 1. However, in patients greater than 75 years, it did cross 1. Therefore, there was no significant effect of statins on this age group. And similarly, in patients who had, or in patients who were at risk for any stroke, patients greater than 75, it again crossed 1. Therefore, the relative risk was not at that significant. Okay. And then the third part of the study was they took participants without vascular disease and participants with vascular disease, and then showed what was the effect of statins in this group. So in another way, what they were actually looking for is patients without vascular disease. It's almost like equivalent to primary prevention, whereas patients with vascular disease, that was representative of secondary prevention. So in primary prevention, overall, there was a 25% relative risk reduction of major vascular events. However, in patients greater than 70, they didn't see a significant reduction. Although it does show that as you keep going down with all the different ages, that the relative risk was less than 1. Therefore, statins did have an effect on these patients without vascular disease. And for secondary prevention, there is a statistically significant risk reduction, as you can see here. However, in patients greater than 75, it was still, because it doesn't cross 1, the relative risk is still less than 1, so it is significant, or it is effective. Statins are effective in patients greater than 75. So the summary of this presentation was to show that statins produce significant reduction in major vascular event irrespective of age. There is a statistically significant trend towards smaller proportional reduction of major coronary events with increasing age, but not with coronary revascularization or stroke. And primary prevention with statins is not effective in patients greater than 75, whereas secondary prevention is effective. Okay, so based on that, I want you guys to be able to answer this question. So if you have an 80-year-old male who comes in with all these comorbid conditions and is currently on atorvastatin 40, what would you do for this patient, given that you have this allele, this lipid panel? Would you stop the statin? Would you continue statin? Would you increase it to atorva 80, or would you change it to rosuvastatin? Does anyone want to answer?
If anybody wants to put their answer in the chat box, or you can unmute yourself.
Okay, yeah, exactly. So you would continue the statin. So then that was my way of testing or addressing the secondary prevention for patients. Even though they're greater than 75, you would continue the statin. Okay. Similarly, if you have a 75-year-old male with hypertension and he presents for medication management, in addition to other medications, he's also currently on atorvastatin, and this is his lipid panel. What would you do for this person? Would you stop statin? Would you continue the statin? Or would you increase it? Or would you change it to rosuvastatin? Anyone? Oh, sorry. Okay, yes, exactly. Thank you, Dr. Hyde. So you would stop the statin, because even though this patient was started on it, he doesn't necessarily need to be on it. And the reason for that is because as you get older, especially patients who are 75 or above, you don't need primary prevention for statin. And but then it's also an individualized treatment. It depends on, it's like a decision making between you and the patient. So it's a combined decision that you have to make. So some would say I would just continue statin. Some would say stop it, but it really depends on what risk versus benefits. Because one of the side effects of, especially in older people, of having statins is that they have myalgias, they have frequent falls. It could also worsen their dementia. So those are some of the things to consider in patients who are greater than 75. Okay. And then these are my references. And if you guys have any questions, please feel free to ask me.
I have a question.
Yeah.
So in your opening slides, when you talked about the different mechanism by which statins work,
Yeah.
you pointed to potentially decreasing an inflammatory process. Could you put that one up?
Yeah. Mm-hmm.
So improving endothelial function, reducing inflammation. So I'm just curious to see, why were they focused on the reduction on LDL as the factor that brought things together? Because from my understanding, sometimes the statin can be a benefit even if you, regardless of what level of LDL you achieve.
Mm-hmm.
Maybe I'm misinformed, but I found that curious because there may be benefits of LDL that are not necessarily related to the level of LDL you achieve, but perhaps you or Dr. Davidson or Basadua may give us some clarity about that.
Oh, so I'm not sure. They didn't address that in the paper, but one of the inclusion criteria for all these trials was to show that so there were two inclusion trials. One of that was to have one of the major effects was to lower the LDL cholesterol, and they had recruited 1,000 or more patients for a 2-year duration. But why did they specifically look at LDL? I'm not sure why. I guess because that was like one of the major components we look at when we are considering initiating statins for patients. Maybe that's why.
Okay, thank you.
Okay, any other questions?
Anyone else, you're free to unmute or put in the chat box if you'd like.
So I guess the question then is, if you have someone who has a cardiovascular event and is over 75, so like even in your example,
Mm-hmm.
and they are not on statins and their LDL is less than 100, will you still start statins?
If they do have cardiovascular event?
Yeah, so it's a secondary prevention question.
Yeah.
But do you even look at the LDL in that case?
So in that case, based on the guidelines, if they have any of, again, you'd look at the ASCVD risk factor, and if they do fit that criteria of greater than 7%, then you would initiate it. But then if they are above 75, then that's another question. We're like, what is it worth it for this patient to be on the statin at this point?
But if you're breathing at 75, your ASCVD is going to be greater than 7.5.
Okay. Then
I don't know. I'm sorry. I'm not trying to give you a hard time. I'm just trying to understand that process.
No, I know. I understand what you're saying, Dr. Hayan. The question is that I've tried to look that up as well. And in a lot of papers, they're not very clear as to whether you should start or not. And they always say if they're greater than 75 and And are you saying that they just had this cardiovascular event? It was like not recent, like just
Or
recent?
maybe they had it in the past and the doctor who was taking care of them never put them on statin.
Never put that.
And now
Okay.
they're a new patient to you, but
Uh-huh.
their LDL is less than 100. Do you start statins at that point? I'm sure it's a clinical decision.
Yeah, it's a
We're not gonna
clinical
get that.
question. Yeah, you're right. And so it really depends on what are their other risks, if they're increased risk for falls, if they have dementia, like would you wanna, because statins can worsen all those things, right? So you have to consider other aspects and then initiate statin. So it's not just like black and white. You just either start statin or don't start statin. And that's what I've seen in a lot of these papers, that they never give you a clear-cut answer. They always just say, well, it depends on you and your patient.
Excellent answer. Good job.
I think it's interesting. If you look at the slide that's up here now, the mechanism of statins is not just confined to the effect on LDL, right? So it improves endothelial function and reduces inflammation. It seems reasonable that if it's slightly less than 100, you would do that. What I find a little difficult is the issue. If they've got a really, really low LDL, like 40 or something, are they really benefiting from the statin? And I've not ever seen anything definitive to help you definitively answer that question, which is why I think they hedge on that in a lot of these articles.
Mm-hmm. Okay.
Did you happen to see there were a couple of questions there in the chat box?
Okay. Let's see. How do I? Oh. Okay. Attempt to quantify the effect, and you can see the chi-square. It's not significant. Can you go to the first table? Okay. Are you looking, Dr. K, are you talking about this table or the first figure? Next table, okay. Okay. And what was the question here? Next table, okay.
I think I was able to, I'm sorry, unmute you, Dr. Catterdahl. Are you on here are you able to? If you want to say something, I think I had you unmuted.
So he's saying, oh, unmute is not working. Why is it more effective when we don't know the baseline data? I'm not sure why. Why do you say that? Is it because based on the overall, the total 0.77? Yes, okay. So they didn't really explain that in their study. They didn't tell me, like, they don't explain this part without the baseline data. They just wanted us to compare that even without having a baseline LDL, it still has an effect. But they don't specifically tell me why. Yes, I agree. It does seem illogical. Sorry, I don't have a definite answer for that. This is what they showed in their paper, and they don't really. So the problem with one of the issues with the paper is that they don't quite explain their data as well. They kind of just tell you, and they pick and choose what they want to show you with their data.
Sireesha or Dr. Teegala, I wonder if it's because the number of cardiovascular events of people on statins versus not, even though they didn't know how to have the baseline, maybe that's what they compared for the outcomes.
I'm sorry, can you repeat that one more time?
For the effectiveness or for the significant difference between those on statin and without statin, even though there may not be a baseline LDL recorded, there's maybe saying that the outcomes are still improved.
Well, yeah, that's the point that they're trying to make, but they don't explain why is it that it's improved even though we don't have any baseline data versus, with baseline data.
Why would you need baseline data? You're comparing two groups, one that is on less intensive or control, and the other one who is on statin or more intensive. So you're just following them over time. And I think what this table is showing is that you essentially have a lower number where you didn't have the baseline data, but you still have the grouping. You still have the events, and you can still calculate your risk reduction.
Mm-hmm. Yeah, but one thing, it could also be that like in part A, they exclusively removed all patients who were either had heart failure or on dialysis. So, and they don't say if they removed it or not. So maybe that could be the reason. We don't know. Any other questions? Dr. K? Okay.
Well, I think if that's it, we will go ahead and let everybody go. I will send out the evaluation and email again, but if y'all can please help us in providing feedback, and if anything at all, just send me an email or give me a call and I'm happy to help. Thank you very much for presenting today for us.
Thank you.